Good afternoon, everyone. My name is Wendy Fox-Grage, and I'm with NASHP, the National Academy for State Health Policy, and I want to welcome you all to our state webinar that's about continuing key Medicaid home and community-based services flexibilities that were implemented during the public health emergency. And I'm thrilled that we are joined by three amazing state health policymakers and administrators. But before we move on, I want to make sure that we thank the John A. Hartford Foundation for their generous support for making this webinar possible. Next slide. Just a few little logistics, and then we'll get the show on the road. We encourage all of you to ask questions. This is going to be a very interactive format. And so click on that Q&A button and ask away. We'll try to get to as many questions as we can after the presentation and our chit chat with the three speakers. And then just to let you all know that, yes, the slides and the webinar recording, they will be posted after the webinar on the NASHP website, and we'll also send it out to all of the Medicare registrants. Next slide. And there I am. I'm a senior policy fellow with NASHP, and I'm thrilled to be facilitating this webinar today. Next slide. Okay, so here's the rundown. I'm going to give just a quick, brief discussion, kind of give an overview, a 50-state highlight of what's going on in home and community-based services post-public health emergency. And then we're going to get to the really good stuff, and that's a facilitated discussion with our speakers from Colorado, Louisiana, and Montana. And then, as I said, we're going to leave some time for some Q&A from you so that you get your questions answered. Next slide. Okay, so let me give a little bit of background to this busy slide. This is, during the pandemic, states received approval from the federal government to implement many flexibilities within their home and community-based services programs to Medicaid beneficiaries that it needed these services during the pandemic. But then once the public health emergency officially ended, then states were left to decide, did they want to continue with these flexibilities or not? And what this slide is showing is our 50-state study that we did, and all this green shows that, and this is our bottom line finding, is that most states did decide to sustain at least one of the things that they had changed during the pandemic to offer more home and community-based services and a more flexible type of benefit in many ways. So just to tell you a little bit about the color coding, that dark green, the states in the dark green mean that they made 4 or more, or were planning to do 4 or more flexibilities. The lighter green is 1 to 3 flexibilities, and then kind of that no color or very, very light gray is 0 flexibility. So again, this was sort of amazing news to us, good news that a lot of the changes that were made during the pandemic, states were indeed planning to continue. Just to hang 3 quick examples. So for example, at least 23 of the states have decided to extend Medicaid payments to parents, spouses, and legally responsible adults, while another 22 states plan to sustain increased payments for the direct care workers, because we know there's such a shortage of those workers, and they typically have lower payments. And so I think this was really highlighted, our reliance during the pandemic on both family caregivers as well as direct care workers. And I think that this, you see post-pandemic, states really taking some action in this area to keep those supports going. And then finally, as we all know, during the pandemic, we all relied more on virtual or remote options, well, just like I am right now. And so fully 16 of states are told us that they are planning to continue this by conducting evaluations, assessments, and even person-centered planning meetings through remote or virtual options. So I'm thrilled. Let's go ahead and go to the next slide. I'm thrilled to go to tell you a little bit about the 3 states that we're featuring today in our webinar: Colorado, Montana, and Louisiana, that have really done quite a bit in continuing these kinds of reforms. As you can see on the slide, all 3 states are going to be planning to allow payment to family caregivers. All 3 states are planning to increase payment for direct care workers, and all 3 states are planning to add some kind of electronic method for services. And you can see the wide variety of things that these 3 states plan to continue. You don't need to memorize that, because we're going to hear from each of the states now, and then we're going to kind of get that inside scoop of what this really means. So next slide. All right. So why don't we start off, and I'd love for our first speaker to introduce our panelists, to introduce herself. Sarah, you want to come on the screen, give a little background about who you are and a little bit about some of the sustained flexibilities.
Thank you, Wendy. Yeah, so my name is Sarah Hurley, and I am a waiver administrator and unit compliance supervisor at Healthcare Policy and Financing here in Colorado. And, as you can see, some of the sustained flexibilities, include a lot of things that we decided to continue on and have received permanent adoption for, specifically for payments to caregivers, payment rate increases for direct care workers, remote and virtual flexibilities, an expansion to our home delivered meals benefit, the utilization of electronic signatures on some forms for our members, and then some assistive technology services.
Great. We look forward to learning about those really soon. Getting more information from you in just a bit. Okay, now let's go ahead and let's go to Louisiana. Kirsten.
Thanks, Wendy. I'm Kirsten Claybear. I'm the Policy Development Director for the Office of Aging and Adult Services. That's through the Louisiana Department of Health. So some of the PHE flexibilities that we continued, payment to caregivers, we increased rates for our providers, and we mandated that they they do a wage floor and also pass 70% of these rates directly to their workers. We added home delivered meals to one of our the adult day healthcare waiver, and we expanded home delivered meals such as medically tailored meals and nutritional counseling through our community choices waiver, and we added assistive technology services to both of those waiver programs.
Great, thanks so much, Kirsten. Okay, and then Barb from Montana, can you tell us a little bit about what kinds of home and community-based services you're going to extend?
I can. So my name is Barb Smith. I'm the administrator for senior and long-term care in the state of Montana in the Department of Public Health and Human Services. I have one of those units where I span APS, aging services, and home and community-based services for Medicaid. So we've decided things that we are going to implement and sustain are the payment to caregivers. And that is currently in our CFC plan in front of CMS. We have payment rates for direct care workers, and behind that is we had historic Medicaid rates increases provided by our state legislature, upwards to 40% in the home care industry. And then we are trying to promote the remote and virtual flexibilities so that our case managers and some of our attendant services cut out a lot of the driving time and a lot of the risk in the winter of folks not getting services in order to support more people at home.
Great, thank you all so much. Okay, let's go ahead and we'll take down the slides. And then what we'll do is let's go ahead and we'll have sort of an interactive conversation with all of us. Fantastic. All right. Sarah, I'm going to go ahead and ask you the first question, which is, how did you decide which flexibilities to sustain. As you all saw in that big chart, there were a lot of ways your state could have gone. And so how did you decide what to sustain and what did you decide not to in sunset? And then what kinds of things were you considering when you made those decisions? And, did you have a formal kind of process for making the decisions, and kind of what challenges did you encounter and how did you overcome them to get where you are?
That's quite the question. Colorado we started really early in deciding to keep certain flexibilities permanent. So, for our case management agencies, we updated the option to allow for virtual visits for some of the ongoing monitoring visits. And we received approval from CMS in January of 21 to do that. So that's been something that we knew early on that was something we would want to continue with. Specifically also with kind of getting some forms, removing forms that were really unnecessary that we'd always used. But with the pandemic, we saw, oh my gosh, we don't actually need all of these duplicative forms. We can get rid of them, or we can get electronic signatures and not have to rely on people, doing that wet signature and faxing in. We held monthly stakeholder meetings right at the beginning to really try to help inform our stakeholders and get their feedback on what was working and what wasn't, really to ensure that people can stay in their home and community. Really, the things that we had to consider, and I think this is probably true for most states, is that we had to see if something was going to sustain after the public health emergency, specifically, when the ARPA funding maybe ran out. How would we continue on with this? Would we be able to monitor this continually? Some of the things that we decided not to keep really included things that maybe the survey, we kind of halted some surveys during the pandemic, really for the health and safety of our agencies and for the members that were maybe in these alternative care facilities or nursing facilities.
Great. Thanks so much, Sarah. Barb, did some of that ring true for your state as well? Kind of how did you go about, and I know your legislature was very involved as well. So can you kind of give us a little bit of background into that?
So we originally had the thoughts that we really needed to do more for the caregivers. And we've had a longstanding direct care wage program that really needed to be enhanced. And it was just happened to be at the same time that we were doing an across the board study of rates. And so historic rates were passed on to our home care agencies at 40%. The legislature took the word of the providers that they were going to pass that along. So we're anticipating to see how that is going to happen. And the other thing is that we really needed to recognize the family support that is keeping our programs going and the economic stressors that happen when you are a family caregiver. So we do have plans to adopt legally responsible individuals for payment. And that also helps greatly in areas that are rural or frontier-like in order to get services to them. And one other thing that we did do that we haven't quite got all the way implemented is, I guess we're still trying to figure it out, is doing med management virtually so that we can eliminate that one quick visit when really drive time or weather doesn't make it a one-time quick visit.
Yeah, that makes a lot of sense to me. Kirsten, do we have you? I know you've had a little internet issues, but hopefully we got you on the phone. Okay, we'll catch back up with Kirsten in just a minute. So both of you had talked a teeny bit about kind of this, that your time frame, your process for getting CMS approval, right? Because they're the partner in all of this. Sarah, you have approval, is that correct for all these services?
Yeah, we do. Currently, we have approval to continue on with this.
Okay, great. Congrats. And then Barb, where are you with the CMS approval?
We're in the final meeting and final process. We're CFC state, so it's taken a little bit longer than we anticipated.
Okay, fantastic. And then Kirsten, I'm not sure if we got you back yet. Maybe that's her. I'm hearing a doorbell ring. So we'll see if she hops on. We can catch her up in a.
Hi, Wendy. I'm on now.
Okay, excellent. So Kirsten, what we're wondering is, how did your state decide which flexibilities to sustain and which ones to sunset? And, kind of what was your process? And then do you have CMS approval to do it?
Okay, so I was listening to Barb and Sarah, and we kind of did the same thing, for Louisiana, when we were determining which PH flexibilities to continue and discontinue. We looked at our utilization reports during the PHE. We also considered stakeholder input, and funding was a big issue as well. So we wanted to make sure, because we did get some approval through the ARPA spending plan, but we wanted to make sure that we would have funding beyond the ARPA, the end date of the ARPA spending plan. And we also, for our process, some of them went through Louisiana's internal formal process. It went through our financial review committee. The Louisiana Department of Health Secretary, he even weighed in on some of the items that we approved. And some of our items had to go for public notice process. And like the other states stated, we also had the issue with the workforce. So therefore, we allowed legally responsible individuals to be the worker for our so that was a big help, because that's what stakeholders were saying. They can't hire workers, but if we allow legally responsible individuals, then our participants would have workers. And in regards to what's approved, the only item we're waiting on is adding assistive technology as a service under the adult day healthcare waiver. It's posted right now for public comment, and we're intending to send that to CMS by November 11th, but all by CMS through our waiver documents.
Fantastic. Well, congrats to the three of you. You're really far along with all of this. I have my list of questions, but we've actually received a really good question in the chat that I want to ask you all. So I'm going to go off my list and I'm going to go to the audience question just for a second. Ellen's question is, in terms of virtual contacts with participants, what safeguards did you put in place or add in order to ensure the health and safety of individuals? And I know that has been a concern with using the virtual remote. Is there any one of you, Sarah, Barb, or Kirsten, that want to address that question?
Sure, I can start. So, great question, Ellen. Colorado worked with CMS quite extensively to get this kind of approved and in a place where we really are going to ensure, the health and safety of our members. So not all visits can be virtual. It does have to be upon the choice of the member. If they would like to have an in-person visit for all of their monitoring visits, then it's in person. We just found that we have some folks who have maybe been on the waiver programs for so many years that are like, man, I don't think I need a quarterly in-person visit to come in here and to do this. So we can allow 3 virtual visits per year. The annual certification has to be in person. And we also have to have another visit. So 2 visits in person, and then there's the option of having some virtual visits. Hopefully that answered your question.
Thanks so much, Sarah. Barb or Kirsten, do you want to answer that as well?
So we're very similar.
Sure, Wendy.
Oh, sorry, Kristen.
Go ahead, Barb.
We're very similar to Colorado. the only difference is that we only have 2 mandated visits a year. So one is in person and the other is flexible. And we also added the option that during the PHE, when they were in a like a board and care facility or assisted living, in order to enhance tracking what was happening when there was an outbreak, we instigated additional virtual visits to those individuals.
And Kirsten.
Yes, so for Louisiana, we decided to not assessment in-person planning meetings. We are going to allow the virtual option for some quarterly contacts and also for the plan of care meeting. And we also worked closely with CMS. They had lots of questions when we put this in our waiver document. So they had specific questions for us, and we had to put safeguards in place and tell them what we would require when we were doing these virtual visits. One off the top of my head, I remember they said, no video is allowed in the bedroom or the bathroom. So therefore, if a person is bedbound, we had to give specifics because you could not go in the person's bedroom, with the video option.
Great. Thank you all for that. That's really great insight to other states that are considering that. So thank you so much. Okay, let's talk about family caregivers, because all three of you have that in your plans. And what I'm wondering is if you can give us some details on that. We all know that, COVID really put strain on family caregivers. And so I was wondering, can you give us some more information about exactly how you're planning to sort of better support them? Sarah, let's go ahead. We'll start with you.
Great. Thank you, Wendy. So Colorado has 2 consumer-directed options, and we had this prior to the pandemic. We have one it's an agency-based one. So, you can have somebody provide your personal care, but they're enrolled through the agency. And then we have the actual consumer-directed model. Both of these models, we allow to have relatives, which includes spouses and people related by blood to do these services. In addition, we have allowed spouses to do just personal care, agency-based. And then we are actually going to be implementing Community First Choice in January of 2025, so that we can really open up this option for family caregivers.
Great. Thanks so much. Barb, how about you in Montana?
We noticed that during the pandemic, there was a significant drop actually in the number of participants in our CFC program. And after doing some digging, it was really those primary family members that were providing the care at home and not having anybody come into the home. And many of those wanted to continue. And with workforce shortages and what a great relationship, we have adopted that into our CFC program. The second thing we did that we just got approval for is we took some of our MFP capacity building money and adopted writing a contract with T-Care that actually is supportive of the caregivers. So it does a baseline of caregiver health. It has some regular check-ins. They have the ability to call other people when the caregiver is in crisis. So hopefully we'll be able to not only use them as the direct caregiver, but also provide them that support that they need to stay in that role.
Great. Thank you so much. Kirsten.
Yes, thanks, Wendy. So like both Wendy and Barb said, due to worker shortage, so stakeholders voiced to Louisiana that they wanted legally responsible representatives to be the worker. We already allowed family members to serve as direct service workers, but they wanted us to expand and allow legally responsible individuals. So we're currently developing policies and procedures to include the CMS safeguards so we can add this, to our process for legally responsible individuals.
So can I piggyback on that with a follow-up question? Because very much like Ellen's question, can you talk about some of the safeguards that CMS is maybe asking you all to put in when you're expanding the kinds of family caregivers that you're going to pay with the Medicaid dollars? Kirsten, have they gotten back with you? Or I don't know if the other two of you have an idea about, just to make sure that those safeguards are in place.
So what they told us is that we have to ensure that it's the care, it's outside, it's that we have to make sure that this is the best candidate to be the worker. So we just have to put safeguards in place. And basically, we looked at the technical guide and we made sure that we put that language in there for CMS that, that would be what they were looking for when they reviewed our waiver document.
Great. Sarah and Barb, was that similar for you all?
Yeah, I mean, I think with spouses providing, kind of the personal care and homemaker, obviously looking at, that this is outside of what a typical spouse would be doing. But also, we included some limitations that no more than 40 hours a week would a spouse be allowed to provide this care. But yeah, everything else Kirsten said.
My answer is simple, and that is ditto.
That was simple. Okay, very good. Thank you all. Okay, so we now talked a little bit about family caregivers. Now let's go to the professional paid caregivers, because I know that is another commonality all three of you have in your states with expanding payments there. But can you give details? I mean, I know in Louisiana, Kirsten, you've got the 70% that you're open it's then going to go to the direct care worker. I know in Montana, that's a 40% increase. But can you all elaborate and give some details? Like, I mean, were they wage pass-throughs that are mandated that a certain percentage absolutely has to go to the worker? And then I know probably the biggest thing that we've been hearing from states in the long-term care area is around the direct care workforce, better recruitment, better retention, better training, better wages, et cetera. So just wondering, does it tie into sort of a larger initiative, given that, again, COVID just kind of shed a light on kind of this workforce and the different challenges. Barb, let's go ahead. We're going to start this time with you.
So Montana has a couple of things that we've done, and for a long time we've had a direct care worker incentive package. Not to age myself, but I did the first one about 22 years ago, and it's up to $15 million that we give out to the providers, that they have to tell us how they are going to provide it. And over the years, it really has come down to the providers use it mainly for a bonus around the holidays and a bonus at the end of the fiscal year. And so that process has been in place, like I said, for a long time. The wage pass-throughs, we don't exactly have. That's what we're sort of watching to see what happens to the wage market with this historic increase. But I will tell you that when we broke down the rates, that for direct care worker, the median rate that we used in our wage that we used in the rate setting process was $16.70 an hour. So that gave them a lot of room from our average before, which was about $14.85. So we're hoping to see that some of that money moves out there. It's interesting because the legislature directly asked me if that money was going to go to caregivers, and which my answer was not unless you earmark the money, and they chose not to.
Okay. But it's interesting that they did their involvement to make sure there was that markup. Sarah, how about in Colorado?
Yeah, so we started off with a kind of a wage pass-through, but we have actually been doing more of a kind of base wage of $15 an hour, a base wage requirement. And so, we did that in January of 2022, and then we received permanent adoption in all of our waivers that in 23 that there would be a $15 base wage for all direct care workers. And then, of course, with the increases that we get with, the legislature, so just recently a 3% increase, then that gets, raised as well. I guess to your other question of what else are we looking at, through ARPA, so many cool things, we got to do, and we're actually looking at some research on some compensation research. So is it just wages, or are there other things that direct care workers would really like to have and would keep them satisfied in this field? And so we're just really looking to see if, funding differentials, looking at different practices, maybe, daycare for folks, really looking at some other retention things that we can do, maybe that aren't just on that wage.
Great, thanks so much. And Kirsten in Louisiana.
So yes, Louisiana, we increased the provider rates with an effective date of October 1st of 2021. And then the latter part of 2022, providers were mandated to pay the direct worker a minimum wage floor of $9 per hour, and they had to pass 70% of their rate increase directly to the worker. That had to be with the minimum wage floor and in other wage and non-wage benefits. So some of those, we gave them a list of non-wage benefits. It included bonuses, sign-on bonuses, recruitment, retention bonuses. If they wanted to pay them an increased wage above the $9, they could do that. They could pay them vacation leave, sick leave, gas mileage reimbursement, training, uniforms, things like that. So we also required that the providers had to write a detailed policy that identifies the specific methods that they would use to pass this 70% to their workers. We did not have to approve that policy. It was just for their internal purposes. But if they wanted to pay the worker something that was not on that approved list, they had to pay that to the worker and add it to their policy. And we also told them we would conduct audits to ensure that they were paying these payments directly to their workers.
Right. Well, you already answered my follow-up, which is then do you have an audit so then you know that it's going through. So thank you for answering that, because I think that's another key thing is okay, you have all these changes, but then are you monitoring it, right, to see that it really is going to the worker and that it's doing the things you wanted. So you answered that. So thank you so much. Okay, so let's go back to this topic of technology, because I've always thought of home and community-based services as being kind of high touch, low tech. But then we had the pandemic, and lo and behold, now we're a little bit more tech, and all three of you have expansions in some way, shape, or form dealing with technology, whether it's, Kirsten, your assistive technology, or many of you have these remote options and electronic, you'll allow for so many visits in certain instances. So I'm just kind of wondering, during the pandemic, what was your experience with these use of technologies, and how really has it from the Medicaid, from the person and family perspective, how has it changed the way you deliver services in your states and made a difference in their lives? Let's go ahead, and Kirsten, let's try and we'll start with you this time.
Okay, yeah. So for assistive technology, we added this service under both of our waiver programs, the Adult Day Healthcare Waiver and the Community Choices Waiver. And what this allows, it allows our participants to receive a tablet so they can get some of these services virtually. So this will help our support coordinators if the participant wants to give them the option of doing that with this tablet. Another service that we did under the PHE is we implemented the Adult Day Healthcare Health Status Monitoring Service. And this was mainly when the adult day healthcare centers were closed and the participants were unable to go to the center. Our ADHD providers would call them and do an assessment on them just to see, are you okay? Do you need meals? How are you feeling? Are you sick? So they would follow up. And if the person on that call indicated that they needed something, it was the responsibility of the ADHD provider to follow up with maybe their physician or an outside resource. So we decided to add that permanently for the adult day healthcare waiver, this adult day healthcare health status monitoring. So but we modified it a little bit. So what we're allowing is for days that the participant is scheduled to go to the adult day healthcare center and they don't go for whatever reason, the ADHD provider will call them and check on them and see, why they didn't go, do they need something, and they'll have to follow up accordingly.
Great. Thank you so much for that. Barb, how about you? How did these technologies, and I know you're in a frontier state, so I can see with the driving distances and all of that this would be a benefit.
It is a big benefit. The one thing that probably helped us out the most is that we've had assistive technology in our waiver, our home and community waiver, for a long time. And so when we would run across a situation where it would be beneficial and they were enrolled in the waiver, it was easy and quick to get them a tablet, to get them involved. And so that was one blessing. And the other being that really we did have some great case managers out there in the field using that technology to make sure that they were checking on the most vulnerable during the PHE.
Great, thanks so much. And Sarah, can you round us out on this question about technologies and changes in home and community-based services?
Yeah, so we actually adopted the option to have virtual services for 17 of our HCBS services. So a lot. And then we also came up with a new one for remote supports technology. And that's really to have personal care and homemaker tasks that do not require hands-on assistance. And you can do this through a live kind of two-way communication with a remote supports professional. With Kirsten, the adult day program, we're continuing on with virtual with that because our providers came up with some really innovative ways that folks who maybe didn't want to go into the center or couldn't could still participate in some of the programming that was going on there to really stay in touch with folks. So we have found it incredibly beneficial and are really just excited about kind of all of these new options.
That's great. I'm just curious because we had heard of, during the pandemic, especially, there had been, some adult day centers that went out of business or they were struggling during that time. I'm just curious, within your adult day centers that are allowed to use this technology now, are they paid at the same rate then as somebody coming in person?
Yeah, we actually have a different rate structure depending on kind of that. It's a tiered rate structure. So, in person, kind of this group, or this virtual. So there are different rates with that.
And then Barb and Kirsten, is it the same with you all that with the is there a difference in how you pay for in-person versus remote?
Not for us right now.
Okay.
Yes, for Louisiana, the adult day healthcare health status monitoring service is going to be paid at a lower rate.
It just shows you all the differences among states. I think that's why I've always loved working with states. the innovate you all are trying, it's really exciting. The audience, we have Q&A, so ask away. Well, if you ask, we'll make Q&A. People, they're a little shy. I think we said wait till after the presentation, but you don't need to. Go ahead and ask away. And while we do that, I want to switch gears and talk a little bit about nursing homes, because we all know about the tragedy that happened in nursing homes, and we've got a lower nursing home occupancy rate in many states right now. And we know that states have been shifting and trying to move more and more to more home and community-based services and caring for people in their communities. And so just kind of bigger picture, what have been the lessons learned coming out of the pandemic, out of the post, PHE, even though we still have COVID. I mean, it's around with all of its variants. And then kind of what are you thinking big picture with next steps in your state as you're evolving with your home and community-based services systems? Sarah, I know that's a huge question again, so we'll start with you, and then Barb, and then Kirsten.
So I'm the lucky one that gets to start this off. Unfortunately, and Colorado is not unique to this, we didn't have a playbook. So the pandemic happened and it was like, okay, what are we going to do? I think historically, some of the challenges that we've always had were really amplified by the pandemic. And they really required us to think in kind of these new and innovative ways. Out of the pandemic, we came with this knowledge that we needed specific plans for the future for emergencies. This is not going to be the last emergency that we have, unfortunately. And so because of that, what are we going to do in the future? And so we're working with our providers on kind of expanding their emergency preparedness, how they work with our members, do they have plans in place? And then in addition, we're working with our members on kind of, assisting them with plans, maybe things like backup generators, things like that, because unfortunately in Colorado, we have fires, we have different emergencies that happen that aren't just about the pandemic, but this really shed a light on, okay, this is what we need to be doing in the future.
Great, thanks so much. Barb?
So we had some of the same issues where we had providers that weren't prepared. And so we spent some time with aligning our smaller assisted living facilities with our emergency preparedness program through the state in order to get them supplies. Many of them did not have the supplies they needed to be safe during that period of time, especially when we didn't have a vaccine. And then our upcoming governor's conference on aging, we actually have two tracks at the conference, where one is specific member centric on how to be prepared in your home, and the other is working with an array of providers of what they need to think about when something like this happens. And we're happy that the local fire department and disaster emergency release in Cascade County is coming to do it for us. So we've been able to integrate that between the system and between the emergency response staff.
Great, thanks so much. And in Louisiana, Kirsten?
Yes, so, with the COVID-19, lots of challenges and things, we needed to work on. So, and one of our lessons learned is that communication. So we had, webinars, we provided memos, we did frequently asked questions, we did in-person provider meetings, but lesson learned is that maybe next time we would also go a step further and put it on our Louisiana Department of Health social media platform pages. So that would be another way of communicating to our participants, providers, support coordinators, case managers, etc. And one of the main area of focus for the department going forward is we want to refine our cost reporting process, and we want to do routine analysis of rate adequacy.
I noticed that was another commonality all three of you all had with your rate studies and kind of studying with the direct care workforce and the research there. Is this something, is this, I know oftentimes, states look at their rates and they readjust, or is this something that you are more intentional about given the issues with the direct care workforce that we're having right now, and not only nursing homes, but also out in the community as well? Kirsten, you want to answer that one, and then we can go to our other panelists as well, because I know you all are really looking at the rates.
Yeah, so we were always interested in this, but especially because of because of the workforce issue, this is going to the top of our priority list. And this is also in the LDH, Louisiana Department of Health. This is in our business plan. So this is something we are active and dedicated to do.
Great, thank you. Sarah or Barb?
So with our provider rate study that was done by a third party and pretty thorough, we do have laws on the books that have been cleaned up that allow us to require cost reporting from our providers. One thing that we ran into is that, the home care industry not used to doing that. So it's taking a lot of steps in filter change to get that. So probably going to start really small with tell us what your average rate was, what was your overhead, what was your insurance, starting with something very simple rather than the whole complex cost review that you would see like out of a nursing home or something like that.
Yeah, that makes sense. Sarah?
Yeah, a lot of the same. We kind of always are looking at our rates. We actually have a rate review process that's been going on where we have providers and members and different stakeholders who sit on a committee and look at, what are our rates for all of our services and how do they line up with other states, and do we need to come up to some of those? And so, we have that. HCBS is on a 5-year plan, so we continually look at that. We implemented a bunch of rate increases throughout the pandemic that we've actually continued on, but really exactly what Barb was saying too.
Well, this is really impressive. We have another colleague of mine has an additional question for you all, and that is, what you all are doing is really amazing. But what we're wondering is, as you're looking ahead, do you foresee any challenges to continuing kind of the sustainability of these changes? Barb, let's go ahead and we'll start with you to talk about sustainability.
Well, so much of our changes is predicated on, this last great movement in Medicaid provider rate increases. And if we track those and we're adamant of making sure that those are getting to direct care providers or getting out in forms of equipment, our risk is that it's not adopted by the legislature. So it's, I have an unprecedented budget right now for the next 2 years, but that doesn't mean I'll be able to continue at the rate we're going. And, I've been here when we've had to curtail services. It's not fun. So that right now is our biggest risk.
Kirsten, what about you with sustainability?
So for assistive technology and the expansion of home delivered meals under the Community Choices waiver, we added the medically tailored meals and nutritional counseling. Those were approved through ARPA until 2025. So we're hoping that this will be an effective service. These services will be effective for our participants, and we have the funding to continue this long term.
And then Sarah, but what about you? Long-term, short-term, medium-term?
Yeah, same as both. We're dependent on our legislature to kind of continue that funding. And it's great though to see when they do approve funding, we're able to do this, and then we come back the next year and say, look at all that we've done and look how great this is, and we need continued funding year over year. So much like everyone right now, we we have a very nice budget, you know, but we have definitely seen the times where your budget is much more lean. So I think it's just kind of a plan for a rainy day type of thing.
Thanks so much. One of the things I also noticed in your flexibilities is some of your states added onto home delivered meals, and I'm very concerned about food insecurity with these populations, and especially with the cost of food that's just has really gone up. So I'm wondering if one or two or all three of you want to discuss the sort of the value of the expanding home delivered meals, and especially in this time where food prices are high.
You know, so in Colorado, we did expand our home delivered meals service for individuals who are also leaving the hospital. So, you know, oftentimes someone will leave the hospital and maybe aren't able to make kind of their meals or have someone to come in. And so we have kind of a new expansion that when you leave the hospital, you'll get 30 days of home delivered meals service. You know, our home delivery meals program came from our Money Follows the Person. So when that ended, we moved it over into our waivers. But we're hoping that, you know, really expanding it to the population who are just leaving the hospitals will actually, you know, really help with hospital readmissions and improve the health and safety of our participants.
Fantastic. Kirsten or Barb, do you want to talk a little bit about home delivered meals?
So for Louisiana, ours is similar to what Sarah stated. So for the medically tailored meals, it's up to 12 weeks when individuals with certain diagnoses are leaving the hospital or the nursing home. We will provide up to 12 weeks. And for our community choices waiver, there's a capped budget. So they cannot spend more than this for the waiver services. But these these medically tailored meals are outside of that budget. So, you know, it's no risk to the participant to get these meals. We just want to make sure that when they go home from the hospital or the nursing home, that they're getting healthy meals, you know, to help them stay out. So they won't return to the hospital or they won't have to go back to the nursing home.
Yeah, it's interesting that in both of your programs, it's triggered by hospitalization, or as you said, Kirsten, you're at some nursing home back to home admission. Barb, what about in Montana?
Well, we've had meals in our waiver, and we've had AAAs and senior centers ask providers. But what the eye-opening experience for us was early on in the pandemic, in the rural counties on the border of the Dakotas, there were runs on the local small mom and pop grocery stores. And suddenly there was not the food supply in areas, and it was predominantly on Native reservations. So we had to go way outside the box, and we actually had the prison cook chill service deliver out to 3 reservations, and the reservations used their centers or hospitals or casinos to use freezer space, and then they did the delivery. And we got a lot of feedback that that filled in a lot of gaps into service areas quickly. And so now we're trying to expand what we can do both under our aging side and under our home and community-based waiver to make sure that, one, we're ready to go if that ever happens again. And then 2, how can we make sure that those meals that are available are getting out to the folks, especially when they're in super rural areas.
Wow, that is a really innovative solution that you all came up with to meet the need in a pinch there. Sarah and Kirsten, again, I was kind of, now that Barb had talked about that, I was just kind of wondering, were you using, or do you use kind of more traditional meal providers, more like the Meals on Wheels, senior centers, or during the pandemic, did you have to think outside of the box, kind of like Barb did in Montana, to use different types of meal providers?
Yeah, so we do use the typical Meals on Wheels kind of providers, also the kind of the frozen meals that are delivered maybe they aren't stationed in Colorado, but outside, so that people can have that meal. But we have not done something as innovative as Montana on using that. That sounds really fascinating, Barb.
And for Louisiana, we're doing the same. We are allowing, meal providers, the frozen meal. Some providers provide fresh meals. And during the PHE, adult day healthcare waiver, we allow the adult day healthcare provider to be a home delivered meal provider during the PHE.
Great. Yep. That's another innovative solution. So we're down to the last few minutes of this webinar. I just wanted to make sure you all, if there was something we didn't get to, or any kind of last minute closing statements, I just wanted to give you all a chance, just because I know this has gone by so quickly and you all have done so much. Any of you want to kind of last minute thing you'd like to address or sum up? Maybe we did such a good job covering everything.
That's the only thing I would add is that, the saying, you got to think outside the box. Well, post PHE or even during the PHE, the box was significantly larger. And one of our goals is to continue that thought process of, what else is out there. We were shocked when we pulled off the whole thing with prison cook chill. So it made us more of a believer in what we can try, and especially for folks out in remote areas.
I love that. Sarah or Kirsten?
Yeah, I mean, I think Colorado is just, continuing to have, our two aims of making sure, offering services that provide the opportunity for people to live in their home and community. And then really also creating kind of a system that's easy to navigate, and easy access to services for our participants.
That's what we hear about all the time, is just how you get access and making it easy for folks. Kirsten, we're going to let you have the last word here.
Okay, yes, I guess just to piggyback off of what they said is we're trying to make services, more accessible for our participants, for our caregivers. We want, we still have to assure participants' health and safety, but, we listen to the stakeholders, we listen to participants. So, some of their recommendations and move forward with those in our policies and procedures.
Great. Well, hey, I cannot thank you all enough. Thank you, Sarah, Kirsten, Barb. Thanks to the whole NASHB staff. Thanks for everybody watching today. And if you can, at the end of this webinar, if you could please fill out our evaluation so that we can keep on improving and having these types of programs. And with that, thank you. And I hope you all have a wonderful rest of the day and a wonderful weekend.